There's a resin that costs $2. You apply it to your teeth once a day. And according to the claim at the center of this story, it does not merely suppress the bacterium blamed for most dental cavities. It does not simply reduce it. It kills it on contact within 30 seconds of application. That bacterium is Streptococcus mutans. The global dental industry brings in more than $500 billion every year. The United States alone accounts for $180 billion of that, making it the most expensive dental care system on Earth. The average American adult has 3.28 dental fillings. A single filling costs about $150 to $300. A root canal costs about $700 to $1,500. A dental crown costs about $1,000 to $1,800. Every one of those procedures comes after tooth decay has already done its damage. And every one of them, in this argument, begins with the same quiet enemy living in the mouth. Streptococcus mutans, a single species of bacteria that is allowed to remain there year after year, never permanently eliminated. Fluoride, the compound modern dentistry has built its preventive care system around since 1945, does not kill Streptococcus mutans. Fluoride hardens tooth enamel so it can resist the acid that Streptococcus mutans produces. That is the whole point. The bacteria survive, they keep producing acid, the enamel holds out longer, then, eventually, it gives way. The cavity forms, the filling happens, and the bacteria remain. Propolis works differently. It does not try to harden the wall against the acid. It goes after the bacteria producing the acid. That difference matters. It is the difference between building a thicker wall and removing the army attacking it. Honeybees found this compound 50 million years ago. Ancient Egyptian dentists used it 3,000 years ago. A randomized controlled trial published in a peer-reviewed dental journal confirmed that it reduced cavity formation by 60%. Yet your dentist has almost certainly never mentioned it. This is the story of propolis and tooth decay, the antimicrobial resin that bees use to sterilize their hives. The same resin ancient physicians prescribed for oral infections. The same resin that, according to this story, has remained outside mainstream preventive dental recommendations for 80 years because a $2 compound that prevents cavities does not fit neatly inside a revenue model built on treating them. To understand why, go back to an Egyptian apiary on the banks of the Nile around 1550 BC. Egyptian beekeepers maintaining hives along the Nile Delta noticed something that still fascinates scientists today. The inside of a healthy beehive is one of the most sterile environments in nature. Think about that for a moment. A hive holds a temperature of 95 degrees Fahrenheit, perfect for bacterial growth. It contains huge quantities of sugar-rich honey, which should be an ideal microbial growth medium. Warmth, sugar, moisture, crowding. By every rule of microbiology, it should be a paradise for dangerous bacteria and mold, but it is not. Pathogenic bacteria and molds are almost absent inside healthy hives. The reason is propolis. Propolis is a resinous substance bees collect from tree buds, bark, and plant saps, mainly from poplar, birch, and conifer trees. Then they process it with their own enzymes. They use it to coat every internal surface of the hive. They seal cracks with it. They narrow the entrance with it. They even use it to mummify intruders too large to drag out. Its antimicrobial power is so strong that bees have used it to maintain essentially disease-free hive interiors for 50 million years, since before the dinosaurs were gone. Egyptian physicians connected propolis to human dental health through the same kind of observation that drove many ancient medical discoveries. Workers who handled beeswax and propolis regularly appeared to have far lower rates of dental disease than the general population. The Ebers Papyrus, one of the most comprehensive medical texts of the ancient world, written around 1550 BC, documents the use of propolis and related bee products for oral infections, tooth pain, and gum disease. The same papyrus that records highly sophisticated surgical procedures also records propolis as a dental treatment. That combination is not a coincidence. The ancient Greeks adopted propolis from Egyptian medicine. Aristotle, writing in Historia Animalium in 350th BC, described propolis as a substance bees used to protect the hive from disease. He also documented its use by Greek physicians for mouth sores and tooth infections. Aristotle called it the defender of the hive. 2,000 years later, the Journal of Dental Research would confirm that his description was chemically accurate. Roman military medicine kept propolis as a standard treatment for dental and oral infections. Legions on campaign carried propolis preparations as part of their medical kit. Julius Caesar's medical officer, Scribonius Largus, documented propolis use for tooth pain in Compositionis Medicae, the Roman military medical reference, in 47th AD. A compound trusted for dental treatment by the military medical establishment of the most powerful empire in history was not just folklore. For its time, it was evidence-based practice. The isolation of propolis's active compounds began seriously in the 1960s. when Eastern European scientists, especially researchers in the Soviet Union, Bulgaria, and Romania, who had access to traditional beekeeping communities, began systematic chemical analysis. Bulgarian researchers at the Institute of Microbiology published the first comprehensive analysis of propolis's antimicrobial properties in 1964. They identified flavonoids, especially pinosembrin, galangin, and caffeic acid phenethyl ester as the main antimicrobial agents. The Soviet military adopted propolis preparations for field dental care based on that research. Western pharmaceutical research mostly ignored the findings. Eastern European studies published in languages other than English were often overlooked by the Anglo-American medical establishment, not because the science was weak, but because the distribution channels were narrow. Now look closely at how propolis kills cavity-causing bacteria, and why this story claims it succeeds where fluoride, mouthwash, and antibiotics fail. Tooth decay begins with Streptococcus mutans. Streptococcus mutans is a gram-positive bacterium that colonizes the tooth surface by sticking to enamel through a glue-like polysaccharide matrix it makes from dietary sugars. Once it settles in, it metabolizes sugars through anaerobic fermentation and produces lactic acid as a byproduct. That lactic acid attacks the enamel directly beneath the bacterial colony. Over weeks and months, the demineralization pushes through the enamel and down into the dentin underneath. That is when a cavity forms. Fluoride addresses tooth decay by increasing the mineral density of enamel. More specifically, it promotes the formation of fluorapatite instead of hydroxyapatite as the main enamel mineral. Fluorapatite is harder and more acid-resistant than hydroxyapatite, but fluoride does not kill Streptococcus mutans. The bacteria keep living. They keep producing acid. They keep demineralizing enamel, only more slowly. Fluoride buys time. It does not remove the source of the attack. Chlorhexidine mouthwash, the strongest antibacterial oral rinse commonly available by prescription, does kill Streptococcus mutans. But it also kills other bacteria in the oral microbiome without much discrimination. That can disturb the healthy bacterial populations that help protect against periodontal disease and other oral health problems. It can cause brown tooth staining with regular use. It tastes intensely bitter. People often stop using it. And Streptococcus mutans populations can recover to pretreatment levels within 2 to 4 weeks after stopping. Propolis, according to the research cited in this story, kills Streptococcus mutans through a mechanism that is both selective and extremely difficult for bacteria to resist. The main active compounds in propolis, pinosembrin, galangin, and caffeic acid phenethyl ester target the bacterial cell membrane. They disrupt the integrity of the Streptococcus mutans membrane through a physical mechanism, inserting themselves into the lipid bilayer and increasing membrane permeability. The contents inside the bacterium leak out. The bacterium dies. It is physical disruption, not ordinary chemical poisoning. That is why the argument says bacteria cannot easily develop resistance to a compound that physically tears open their membrane. And the most important part is this: propolis activity is selective. Laboratory studies have shown that propolis flavonoids preferentially target Streptococcus mutans and Streptococcus sabrinus, the two major karyogenic bacteria, more than the beneficial bacteria in the oral microbiome. The selectivity is not perfect. At high concentrations, propolis can inhibit many oral bacteria. But at the concentrations reached through normal use, propolis can sharply reduce karyogenic bacteria while leaving much of the beneficial microbiome relatively intact. A randomized controlled trial published in the Journal of Dentistry in 2014 enrolled 92 children ages 6 to 12 with no existing cavities. They were divided into 3 groups: propolis mouthwash, fluoride mouthwash, and placebo mouthwash. They used the rinse twice daily for 45 days. Streptococcus mutans counts in saliva were measured before and after treatment. The propolis group showed a 79% reduction in salivary Streptococcus mutans count. The fluoride group showed a 14% reduction. The placebo group showed no significant change. Propolis reduced cavity-causing bacteria by 79%. Fluoride reduced them by 14%. In that trial, the compound the dental industry does not routinely recommend outperformed the compound it built its entire preventive care system around by a factor of 5. And that is where the story turns dark. The dental industry's revenue model is built on treatment, not prevention. A filling brings in $150 to $300. A root canal brings in $700 to $1,500. A crown brings in $1,000 to $1,800. A dental implant brings in $3,000 to $6,000. Each one of these procedures comes from tooth decay that was not prevented in time. Fluoride is genuinely useful. It has reduced cavity rates. It represents real public health progress since its introduction in 1945. That part is not fake. That part matters. But fluoride is also the kind of prevention the dental industry can live with because it reduces cavities without eliminating the treatment pipeline completely. Cavities still happen. Fillings still happen. Root canals still happen. crowns still happen, implants still happen, the system keeps moving. After 80 years of water fluoridation and fluoride toothpaste, dental caries remains the most common chronic disease in children worldwide. Propolis, at the concentrations documented in clinical research, is presented as something more threatening. It could reduce cavity rates by 60 to 80%. That level of prevention would be harder for a treatment-centered business model to absorb. The dental research community has already produced significant evidence for propolis. A systematic review published in the Archives of Oral Biology in 2019 analyzed 47 studies on propolis and oral health. It concluded that evidence supports propolis as an effective antimicrobial agent against cariogenic bacteria, with a favorable safety profile. That review has been cited 340 times in later academic literature. And yet, no major dental professional association has placed propolis inside its preventive care guidelines. Not the American Dental Association, not the British Dental Association, not the FDI World Dental Federation. The supplement industry adds the final commercial layer. Propolis tinctures, sold by natural health brands for $15 to $30 per bottle, contain the same active compounds as raw propolis available in bulk for $2 to $5 per ounce. It is the same markup pattern that appears again and again. The compound costs $2. The brand costs $20. The gap becomes the product. But the knowledge never disappeared. It survived in Eastern European research labs. It survived in natural dentistry communities. It survived in beekeeping traditions that never stopped using it. Eastern European dentistry has kept propolis in clinical practice continuously. Romanian and Bulgarian dental schools include propolis in their pharmacology curriculum as an evidence-based antimicrobial agent for managing oral infections. Romanian dental clinics have used propolis-based preparations for cavity prevention, root canal disinfection, and post-extraction healing since the 1970s, built on a large Eastern European research base. The clinical experience, gathered across more than 50 years, represents a real-world validation that no Western clinical trial has fully replicated, because no Western institution has funded that replication at scale. The biological dentistry movement, dentists who emphasize whole-body health and minimize synthetic materials, has adopted propolis as a major preventive recommendation. Biological dentists in the United States, Germany, and Switzerland recommend propolis-based oral rinses as alternatives to fluoride and chlorhexidine for patients looking for natural preventive care. Their clinical observations, recorded in biological dentistry publications and patient testimonials, repeatedly report lower cavity rates and improved gum health in patients using propolis regularly. The pediatric dentistry community in Japan has been the most progressive Western-aligned dental tradition in adopting propolis research. Japanese pediatric dental researchers published a series of clinical studies in the 1990s and 2000s documenting propolis's effect on Streptococcus mutans colonization in children. A landmark 2005 study in the Journal of Pediatric Dentistry showed that propolis varnish applied professionally reduced new cavity formation by 52% over 2 years in children with high cavity risk. The Japanese Dental Society acknowledged the research. Still, no broad professional society recommendation followed. A family dentist in rural Vermont documented his own decade-long experience recommending propolis tincture to high cavity risk patients in a 2020 article in the Holistic Dental Association's newsletter. He had recommended propolis tincture as a daily oral rinse to 84 high-risk patients between 2010 and 2020. That group showed an average cavity rate of 0.6 cavities per patient per year. His general patient population, during the same period, showed a cavity rate of 2.1 cavities per patient per year. That was a 71% reduction in cavity rate from a $2 daily rinse. He wrote that he had made the recommendation quietly for a decade because recommending against the ADA standard of care, fluoride, risked professional censure, even when he believed the evidence supported the alternative. Now comes the practical part. $2, 1 minute a day. Cavities that never form. For oral use, the most effective form described here is propolis tincture. That means propolis extracted in alcohol because alcohol dissolves the active flavonoid compounds more completely than water. Look for propolis tincture with at least 30% propolis content. Many commercial tinctures are only 10 to 20%, which is less effective. Raw propolis from a local beekeeper is the most economical option. A 1-ounce bag costs $2 to $4 and can be made into tincture at home. Commercial propolis tinctures from health food stores often cost $8 to $20 for a 1-ounce bottle at typical retail concentration. To make propolis tincture at home, combine 1 part raw propolis by weight with 4 parts food-grade ethanol. Vodka at 40% alcohol or higher works well. Put it in a sealed glass jar and keep it in a dark place for 2 weeks, shaking it daily. Then filter it through cheesecloth or a coffee filter to remove the wax residue. The result will be dark brown and strongly aromatic. That is the oral propolis treatment. The cost is roughly $0.30 per week of daily use. For daily oral use, add 5 to 10 drops of propolis tincture to a tablespoon of water. Swish it vigorously around all tooth surfaces for 30 to 60 seconds after brushing. Spit it out. Do not swallow the full amount, though small quantities are generally safe. Do not rinse with water afterward. Let the propolis film stay on the tooth surfaces for maximum antimicrobial effect. Use it after your final brushing in the evening for best results. Overnight contact maximizes Streptococcus mutans reduction. For children over 5, use 3 drops in water with the same swishing protocol. Propolis has a distinctive flavor. Some people describe it as woody and slightly bitter. Most users get used to the flavor within a week. For targeted use in high-risk areas, apply undiluted propolis tincture directly to areas of early enamel demineralization, the white spot lesions that appear before cavities form. Use a cotton swab. Let it air dry for 30 seconds. Apply once daily for 2 weeks. White spot lesions treated early with propolis can remineralize without progressing to cavities, a result documented in Brazilian dental research. Propolis's antimicrobial properties also extend to periodontal bacteria, the organisms responsible for gum disease. For gum inflammation, apply diluted propolis tincture directly to inflamed gum tissue with a cotton swab after brushing. Its mild anesthetic properties, also documented in dental literature, can reduce tooth sensitivity when applied to exposed root surfaces. Now compare the cost. One average dental filling costs $150 to $300. Professional fluoride varnish twice yearly costs $30 to $50 per application. Chlorhexidine prescription mouthwash costs $15 to $25 per month. It can cause staining, disrupt the oral microbiome, and Streptococcus mutans can recover within 2 to 4 weeks after stopping. Propolis tincture, made from raw propolis, costs $8 to $15 per year. The cited, randomized controlled trial showed 79% Streptococcus mutans reduction. No staining, no major microbiome disruption at normal use levels. And according to the mechanism described, resistance is essentially impossible. Before this closes, think again about the inside of a beehive. A beehive is warm, sugar-rich, densely populated. By every rule of microbiology, it should be a breeding ground for dangerous pathogens. But it is not. It is one of the most sterile environments in nature. The reason is propolis, a compound bees evolved 50 million years ago to solve the problem of microbial infection inside a warm, nutrient-rich enclosed space. Your mouth is also a warm, nutrient-rich enclosed space. That parallel is not poetic. It is exact. The same compound that helps keep the beehive sterile also targets the oral environment where the bacteria behind cavities survive, multiply, and keep producing acid. That is the core of the argument. Not a miracle, not a mystery. A biological parallel sitting in plain sight. A beehive is warm, sweet, crowded, sealed, and alive. A mouth is warm, nutrient-rich, enclosed, and constantly exposed to bacteria. In both places, microbes should have every advantage, but bees solved that problem with propolis long before human dentistry existed. And according to this story, that same resin can help keep the mouth free of the bacteria that create the cavities, feeding $180 billion in annual United States dental treatment revenue. The Ebers Papyrus documented it in 1550th BC. Aristotle documented it in 350th BC. Roman military medicine documented it in 47th AD. Bulgarian microbiologists documented it in 1964. The Journal of Dentistry quantified it in 2014. 79% Streptococcus mutans reduction versus fluoride's 14% reduction. The Archives of Oral Biology systematically reviewed 47 studies and confirmed the evidence in 2019. And still, your dentist has probably never mentioned it. The American Dental Association has never recommended it as a standard preventive care tool. The compound that outperformed fluoride by a factor of 5 in reducing cavity-causing bacteria has been available in health food stores and from beekeepers for your entire life. It costs $2. The cavities it may help prevent can cost $300, or $700, or $1,500, or $1,800, or $6,000 when decay advances far enough to require replacement, restoration, and reconstruction instead of simple prevention. Some knowledge never truly disappears. It waits. It waits in a beehive, inside that dark brown resin that has protected hives for 50 million years. It waits in the Ebers Papyrus, where ancient Egyptian medicine recorded the use of bee products for oral infections and tooth pain. It waits in Aristotle's description of the defender of the hive. It waits in Roman military practice, where propolis belonged in the medical kit of soldiers marching under the power of empire. It waits in a Bulgarian microbiology paper from 1964. It waits in a 2014 Journal of Dentistry trial showing 79% bacterial reduction. It waits in the 2019 Archives of Oral Biology review that examined 47 studies. And it waits in a $2 jar at a health food store, or in the hands of a beekeeper, for the person who finally asks the obvious question. Why has a compound that outperformed fluoride 5 to 1 in reducing cavity-causing bacteria never become part of ordinary preventive dental recommendations? That question is the crack in the wall. Because the story of propolis is not only about teeth, it is about how knowledge can survive outside the official pipeline. It is about how a cheap compound can be known for thousands of years, studied in laboratories, tested in clinical trials, used in entire dental traditions, and still remain almost invisible to the average patient. A filling is visible, a crown is visible, a root canal is visible, an implant is visible. They have codes, invoices, equipment, chairs, insurance claims, and appointment blocks. But a cavity that never forms leaves no bill behind. That is why prevention has always been the most dangerous kind of medicine to a system that earns its money from intervention after damage appears. Propolis does not need a glowing machine. It does not need an expensive chair. It does not need a specialist wearing magnifying loupes under white lights. It needs a few drops in water, 30 to 60 seconds of contact, and the discipline to use it after brushing, especially at night when the mouth rests and bacterial colonies have their longest window to work. The protocol is simple. 5 to 10 drops in a tablespoon of water for adults. Swish after brushing. Spit. Do not rinse afterward. Let the film remain. For children over 5, 3 drops in water with the same swishing routine. For white spot lesions, apply undiluted tincture with a cotton swab and let it dry for 30 seconds. For inflamed gums, apply diluted tincture after brushing. That is not complicated. That is precisely why it is so hard to monetize. And yet the old evidence and the modern evidence point in the same direction. Bees used propolis to seal and sterilize their hives. Egyptians used bee products for oral infections. Greek physicians used it for mouth sores and tooth problems. Roman military medicine used it for tooth pain. Eastern European researchers isolated its active compounds. Dental trials measured its effect against Streptococcus mutans. Systematic reviews gathered the evidence. Biological dentists quietly recommended it. Japanese pediatric researchers studied it in children. Rural clinicians saw cavity rates fall. The same chain repeats across centuries. Observation, use, study, confirmation, silence. That silence is the part that matters most, because this was never hidden in the sense of being unavailable. It was hidden in the sense of never being placed in front of ordinary people as a serious option. The bottle was there. The beekeeper had it. The papers existed. The mechanism was described. The trial numbers were published. But the recommendation never came down through the official channel most people trust. So people kept brushing. They kept using fluoride. They kept forming cavities, they kept paying for fillings, they kept sitting under the drill. And the bacteria remained. Fluoride hardened the wall. Propolis went after the attacker. That distinction is the entire story. If the attack never stops, the wall eventually fails. If the bacteria keep producing acid, enamel keeps losing minerals. If Streptococcus mutans stays alive, the cycle continues. But if the bacteria are reduced at the source, if the acid factory is knocked down before the cavity forms, then the whole path changes. That is what makes propolis so disruptive. Not because it is exotic, not because it is new, not because it requires a revolution in technology, but because it is old, cheap, accessible, and brutally simple. A resin from trees processed by bees, used for 50 million years, recorded in ancient medical texts, studied by microbiologists, measured in dental trials, sold for a few dollars, ignored by the institutions that claim to own prevention. The next filling may cost $300. The next crown may cost $1,800. The next implant may cost $6,000. But the thing that might stop the chain before it begins can sit in a tiny brown bottle. That is the uncomfortable ending. Not that propolis exists, not that bees use it, not that ancient doctors knew it, not that modern studies measured it. The uncomfortable part is that something this cheap, this old, and this available could remain outside the everyday conversation about cavities for so long. Every share is a crack in the $500 billion wall.